Hello again, this is Dr. McClellan, and welcome back to Gate 3, The Sorrows of the World. Last week, we widened the clinical room, so to say, in order to recognize that grief is carried by communities, histories, systems, and public life. And this week, we're going to remain inside Gate 3 and focus on grief that may be unrecognized, stigmatized, socially constrained, ambiguous, or unresolved. Our focus here is grief that has no clear social permission, grief that cannot be resolved through certainty or closure. And as social workers, we need language for both of those experiences because our clients may be carrying not only that loss, but also the burden of having that loss be minimized or questioned or left really without ritual and witness. And so our central clinical task here is recognition with humility, enough clarity to name grief as a possibility, and enough attention to understand the context, and enough restraint not to impose legitimacy or meaning or closure on someone else's experience. So, some losses hurt twice. First, there's the loss or the absence or the change or the uncertainty itself. And then there's the social response that says the relationship did not count, the loss is not serious, the mourner is not legitimate for some reason, or even that the grief should already be over. Recognition is therefore part of our clinical intervention. We can say tentatively, I wonder whether grief is part of what you're carrying, for example, or this sounds like a meaningful loss. And these statements really invite the client's meaning without defining it for them. So the social worker does not grant permission for grief as though the grief belongs to us to authorize. Instead, we make space for it. We make room for the client to name what has changed, what is left, who recognizes the loss that they experienced, and what has made mourning difficult or unsafe for them. Disenfranchised grief occurs when grief is not openly acknowledged, publicly mourned, or socially supported. This disenfranchisement may come through the relationship, through the loss, the griever, or even the way that mourning is expressed. It may be because the relationship's unrecognized, like with the former partner or chosen family member or friend or a pet, for example, or a client you can't talk about, or relationships others don't really validate. Those can all be unrecognized. It could also be minimized, like a loss due to miscarriage or infertility, abortion. Migration losses can be invisible to others. Estrangement, disability, where you grieve the loss of the life you can't have. Chronic illness, loss of identity, loss of home. A mourner themselves may be treated as illegitimate because of their age or their disability, because they're incarcerated, because of their professional role, their caregiving role, or even their marginalized social location. And then mourning itself can be judged, maybe by its timing, its intensity, its ritual, or if its expression falls outside of what we expect as a family, as a culture, as an institution, or even just as a general public. These four forms, these categories, are not a diagnostic checklist, though. They just help us to think it through. They help us to ask how the social environment is shaping access to witness, to ritual, to language, to safety, support, right? Because as social workers, we always want to be looking at the person within the context of their family and their environment. So gate 3 carries two common clinical risks. The first is forcing certainty. When a person faces unresolved absence or change, sometimes the clinician feels pressure to close the gap to check the box, to create the answer. You need to accept that the person is gone. You need to stop hoping. You need to choose a meaning. You need to somehow move towards closure. But the situation itself may remain uncertain. We need to be able to accept that and the client exactly where they are right now. The second risk is kind of the opposite. It's minimizing the grief while trying to decide whether or not it's legitimate. So we can be making comparisons or reassuring the client. We can be considering timelines or giving spiritual explanations that the client did not choose. Maybe even demands for proof. Those kinds of expectations of our clients can reproduce the same social invalidation that brought them to the room. Recognition does not mean that the clinician defines the loss or abandons the assessment. It means we assess their suffering, their functioning, their safety, context, culture, and their strengths without making public permission a condition of care. We are working directly with that person and or family. We do not need the outside world to agree with us. We can just join them here in the grief they're experiencing. So in your literature for this unit, Pauline Boss describes ambiguous loss as loss that remains unclear or unresolved. One form involves a person who's physically absent but psychologically present. So their ghost is still present in this person's life. They're missing, deported, they're incarcerated, they're separated. Another involves someone who's physically right there in the room, but psychologically altered or unavailable, like a parent with dementia or a partner with traumatic brain injury. A person who has severe mental illness is no longer available to parent you, for example. A person with addiction, chronic illness, or trauma could also become, while physically present, psychologically altered or unavailable. Ambiguity can also surround a role, an identity, a relationship, a homeland, a community, or even an expected future. This ambiguity can disrupt the markers that often organize our mourning as humans. There's no confirmed ending, no stable role or ritual, no clear decision or final answer for us to push off of. And so our clinical response is not to manufacture closure. We support both and thinking here. The person is absent and the relationship remains present. Or the loved one is here and something important has changed. I can hold hope and I can protect myself. So with the client, we help build meaning and connection and role flexibility and tolerance for uncertainty through our example of holding the space for them, through our acceptance of them in relationship. So let's return to the Alvarez family again, and let's hold this case again with questions rather than conclusions. We can just stay with them here in this space and look for grief connected to migration or family separation, role changes, caregiving, illness, economic stress, legal uncertainty, community violence. These are becoming familiar refrains now as we consider their loss of identity or cultural expectations, and ask what grief may lack clear social permission, right? What remains ambiguous for them? What's ongoing or unresolved? Through this lens, who may feel unable to mourn openly? What family roles or policies or institutions or cultural expectations shape their experience? So again, validation of their experience does not mean that we assume that closure is possible or desirable. It may involve naming the loss and supporting the conversation. It may involve working with them to create a culturally congruent ritual to support their healing, or connecting them to their community, or addressing a practical barrier to their resolution of some of this. Or it could just be refusing to minimize what they're carrying and staying with them in that experience. You want to keep the formulation really open and client defined. So for this week's practice, you're going to write one response that recognizes grief without forcing closure. And you're going to begin with recognition. You might say, this sounds like a meaningful loss, right? It's a simple way to express that you have a question about this part. You want to explore this a little bit. You are curious. Maybe, I wonder whether grief is part of what you are carrying. I'm talking about really simple examples of communicating this curiosity. And if the ambiguity is central, ask, perhaps, what remains uncertain right now? And then protect the client's meaning. Make sure that you're asking them what the loss means. Who recognizes it? What has made this mourning difficult for them? And what kind of acknowledgement or support would fit here? You're going to avoid advice or comparison, imposed ritual, timelines, premature reassurance for sure. That's always trying to make ourselves more comfortable. Or demands for acceptance of our conceptualization. And then review your response. And does it name grief tentatively? Does it preserve the client's authorship and attend to culture and power and safety and context? Does it make room for uncertainty? And the goal is language that communicates your grief does not need public permission to deserve care. That's what you want them to hear. So this gate 3 takeaway is, again, to honor uncertainty and restore recognition. Disenfranchised grief directs our attention to social permission, whose relationships and losses and grief expressions and identities are recognized. Ambiguous loss directs our attention to unresolved uncertainty, what is absent, what remains, and what cannot be settled just because we demand closure. Grief-informed social work supports dignity and meaning and connection always. We uplift and honor ritual and advocacy and choice while allowing the client to remain the author of their experience. Our practice asks who has the power to decide whether grief is legitimate and how institutions and policies distribute time and safety and witness and support. An interesting example of that is if you have a pregnancy loss, even if it's very late term, you're no longer eligible for maternity leave because you didn't have the baby. And so often women are expected to return immediately to work after a late term pregnancy loss. So carry this forward. We want to recognize grief that has been denied recognition. We want to honor what remains unresolved. And we make sure that we do not require closure of our clients as evidence of their healing or their evolution.